We're going to look at 6 common topics. I'm going to look at the first 3, and Andrew's going to look at the last 3. So I'm going to start off with male LUTs. I think we've got the pathways, but today's really about giving a bit of some overview, some key points that I think about things. The health pathway documents are very helpful in terms of going into some details. And I think the key things that I think in men with urinary symptoms is 1, to get the correct diagnosis. 2, we've got to make sure that there's no dangerous signs. And to make you guys feel confident about medical management. Often, which drugs should I, can I give? When do I have to send to a urologist? And so, if you go onto the health pathways, this is what you'll find. And these are the key things that I think. So if I'm seeing a patient with LUTs, the first thing that you want to find out is about the symptoms. But the key thing about the symptoms is really about how much bother. Because some men might get up once per night and think it's the worst thing in the world, whereas you may have another patient who gets up 3 or 4 times a night and he thinks, well, that's just normal for me. So you do have to work out the bother. We use things like the IPSS forms, and that's in essence just trying to kind of quantify that. But it's just simple questions, What's your flow like? How often do you go? If you've got the urge to go, can you hold on? And then the key thing that I always ask at the end is, if you had to live your life, the rest of your life the way you are now, how would you feel? Or often actually how I rephrase it, just say, do you think your symptoms are bad enough that you'd want to try medication? Because that often gives you a gauge in terms of how bad or how much bother. And then the next thing in the consult then is to kind of rule out those red flags. So do you find that you have incontinence? Do you wet the bed at night? Do you have any pain, new pains in your body? Have you had any blood in your urine? So trying to work out what might be those red flags. But for most men, the important point is that you don't need to do lots of investigations. They don't need a cystoscopy. They don't need an ultrasound. They don't need all of these things unless there's other concerning factors. You can get straight on and treat these guys with medication. So if we look at the management, again, lots of stuff on the health pathway, which is a great document. But if I break that down into one slide, common things are common, so get on and treat. If a man comes to you and he's got problems passing urine and his flow's not so good, start him on an alpha blocker after giving him some counselling. It's amazing how good men's symptoms will improve on an alpha blocker. You can tell them, 40% of men will notice a significant improvement in their symptoms. So get on and give them treatment. And have a stepwise approach. Start with a non-selective alpha blocker because that's what's funded, doxycycline. Or if you have a patient who you're worried about blood pressure, particularly in the very elderly men, you can go straight to trazodone, which is a selective alpha blocker. So that should not lower their blood pressure or cause postural hypotension. And there's a special authority for that. And you don't have to have just had them on doxycycline. You can put them straight onto that if you think that doxycycline would be contraindicated. If you've given them that medication, they've still got some urgency frequency symptoms, try an anticholinergic. We're always very worried about, is this going to give me retention? Very unusual. So actually treat the symptoms, and solifenacin now is fully funded, so I would not prescribe oxybutynin. The amount of dry mouth, if you look at the studies, 50% of people who go into oxybutynin stop it because of the side effects. So you can go straight to 5 milligrams of solifenacin. It's not a special authority anymore. So none of you, you shouldn't be using oxybutynin. The only advantage of oxybutynin is it's a bit more short acting compared to solifenacin. Where does finasteride fit into all of that? Again, the special authority is for men who have either been non-tolerant or have not had improvement in their symptoms on an alpha blocker. I'm a little bit wary in men who are younger men, because there are some anecdotal and there are reports around the effect on sexual function. And so often men will Google this and they'll be very concerned, and actually you'll find it difficult to get them onto it. But in older men, it's a great drug. Side effects are very rare, and so I would consider that. You can give men all of these medications before they need to come and see us. So if medication fails or if there are red flags, they would be the time to refer. And when they come and see us, there's lots of things we can do surgically. 3 groups that I think people find difficult. The first one is I see a more common coming out in is young men with irritative voiding symptoms. And they're really hard to know what to do with because they're very affected by this and you don't really know where to go with it. And so these men, again, I would go through the stepwise approach in terms of the pathway, but they may need to come and see a urologist at an earlier point if you're not seeing any benefit. But invariably, it's more along a painful bladder syndrome, kind of irritable bladder syndrome, rather than being outflow obstruction. The other group that I find very difficult sometimes is the elderly, because comorbidities, rest home, how much medication, if I give them this medication, they're already on all these other medications, what can we do? Hey, but I don't know if they'll be fit for surgery, so, expectations around that. So again, I think they are more difficult. So it's just, again, looking at the pathways, but this is where often I see men not being given terazosin, so that's worth a try. Often they go, oh, Doc terazosin was contraindicated, there's nothing else I can do for this man, Hey, finasteride could be a good option in this setting. And the other group is the men who have primary nocturia, because nocturia is very difficult to treat compared to men who've got problems passing urine. If you've got a weak stream, I can make your stream really good by opening up your prostate. I can't necessarily improve your nocturia from 3 times to 0 times. And the reason for that is often a multifactorial cause, obstructive sleep apnea, diabetes, change in fluid balance and hormonal levels as they get older. So I think a bladder diary in these patients is, again, a very important tool. And what we're looking for is polyuria nocturia. What does that mean? It means they pass a lot of urine at night. What is the exact definition? It's 1/3 of your volume in a 24-hour period. So the reason why that's important is that actually trying a low dose of a diuretic can be very helpful, because what you're trying to do is offset some of that fluid during the day. Because as I always say to a man, it doesn't matter how good I make your prostate, if you're still going to produce 1.5 litres of urine overnight, it's got to go somewhere. So what we need to try and do is, can we change where that 1.5 litres is into the day? And that's what you're thinking from treatment.
So alpha blocker will not reduce nocturia?
They will, but often if the people who have primary nocturia, and not many other symptoms, they're particularly the group that can be quite difficult to manage, because I think there's other factors involved. Absolutely, I think within the pathway you should look at that, but being aware that there may not be as improvement in that, and so you may get along that path and then have to think about that. As said, we're going to try and move through things quickly. They were just some 3 kind of key points. Looking at recurrent UTIs, which I think again is something very common. It's late in the day, we thought we might need to have a couple of jokes in here. So recurrent UTIs are extremely common. Females, when they have a UTI, have a very high chance of developing recurrent UTIs. What is the definition? Well, it's more than 3 in a 12-month period, or more than 2 in a 6-month period. And that is, and the biggest thing that I find when I'm in the hospital system is I want to be able to see that they've been documented on lab test, because that's hard, because they'll come and tell you, oh, I've been having urine infections for months. And you go onto the system and you go, I can't see a single urine sample having been done, So I do think if you're moving into this stage of recurrent UTIs, getting urine samples is very helpful, particularly if they come and see someone, because then we can actually see what's been happening. If I see a patient, what am I doing? I think the first thing is about establishing diagnosis, because the biggest problem I have often is this really recurrent UTIs, or is this an irritable bladder, overactive bladder, interstitial cystitis, painful bladder syndrome? So the first question, what are your symptoms like when you get infection? Oh, I find I just go to the toilet lots. Okay, do you have any burning when you pass urine? Do you have any fever? Do you feel unwell? Do you have a change in the urine colour or odour? Trying to get an idea about things, because sometimes the symptoms they tell purely fit into very overactive bladder. So you just want to make clear about that. Because the problem is you can have antibiotics and feel a lot better, but it may have just been because you're on a cycle and you're just feeling a lot better just because you've taken any treatment. I'm then asking about red flags, and one of the important points to say, particularly in females over the age of 50 who start developing urinary symptoms, we always need to be aware about bladder cancer. Very, very rare, but there is quite clear evidence, and Andrew will talk about it later, that females often present later than men bladder cancer because we go, oh no, that's just a urinary tract infection. So have they had blood in their urine? When they had blood, was there actually an infection associated with it? If there wasn't, hey, red flags up there, you know? Are they having different types of organisms? Have they had recent surgery? Have they had a past urological history where there may be something going on? You know, when I was hit by this recently, I saw a patient for probably about 6 months, and she seemed fine, you know, getting recurrent UTIs, and we didn't know what was going on. Oh, is it her kidney, is it not? We'd done a CT IVU, hadn't found anything, and then it took an MRI, because she'd had a previous difficult vaginal delivery, for us to finally find the vesicovaginal fistula. And not that that's something you may ever see, but just we've always got to be thinking about other things in terms of that. The other part of the consult I find is then there's this whole investigation point of view, but then there's also solution point of view, because they haven't come to you, you know, they wanted to get rid of these infections. So part of the discussion already is talking through, hey, UTIs are really common. This is often a common in this age group. There are different things that we can do as you're moving along. So this is again taken from Health Pathways. Again, I'm going to break it down into 3 points. Ensure it is actually a recurrent UTI before you go down this path. You know, as I said, you want to document this. With more direct-to-pharmacy trimethoprim by your patients, you may not be as aware of how many infections they've actually been having. And so you do need to ask them about that. Have you been going to a pharmacy? Have you gone to an after-hours centre? Because often you may think that this is the first time you've seen them for a UTI, but they may have been presenting a number of times. And when I break it down and I'm thinking about it, I'm going, there's 3 reasons why I could have a recurrent UTI. One, there's a structural abnormality. So in a man, maybe the bladder's not emptying, so they're getting a pool of urine that's from an infection. Have they got a kidney stone? Have they got something abnormal? So is there a structural abnormality? And that's why an ultrasound is a great test. Next, I'm going, is it something wrong with the host? You know, are they immunocompromised? Have they got uncontrolled diabetes? And third, is there something about this bacteria that we're not quite getting to picture? Have they had appropriate antibiotics? Has the course been appropriate? And kind of from my simplistic way of thinking, that's kind of how I break it down. And so then I can kind of tick off and can say, well, structurally we know that things look fine. Host, you know, this is where we're looking. So in terms of treatment, so again, document health pathway. Again, I break it down really to 2 things. So the first is around prophylaxis, because that's often what we end up in this situation. And I break it into non-antibiotic versus antibiotic. And I'm sure we've all seen the shift with our patients. Patients don't want to take antibiotics. They're very worried. They want to try anything, you know. And so the first thing they're often going to go down the pathway is in terms of these non-prophylactic. And I think it's a good choice because we know that the side effects, we know the problems with antibiotics. So we've got cranberry. And the thing often happens, it seems 1 week you get a meta-analysis that says it's great, the next week it's not. I think at the moment it's kind of back in vogue. I know in America in terms of the guidelines that it is. We've seen a lot of benefit for patients with D-mannose or Eurofem. And you know, there is a study that has shown compared to nitrofurantoin for E. coli infections that it was just as good. But that was in the setting of E. coli. Hiprex, again, partially funded if you give them the right number of doses. I think you have to give them 60 tablets. They do need to take that with vitamin C because of the way that the nature, you need an acidic bladder for the compound to break down. And one that we're actually using a lot more because we often are seeing people at the end of the line is the Euroimmune, the nasal vaccine. We've had some great outcomes from this. It is a section 29 drug, so in terms of prescribing, patients need to be aware of that. In terms of antibiotics, so I'd usually go with 150 of trimethoprim or 50 of nitrofurantoin per night. People often ask, do you switch them around? Do you give them for 1 month, 3 months? The science is not exact around that, but I think you've got to be expecting that they're going to be on it for somewhere between 3 to 6 months. And that it's not going to magically fix them. Once they come off that, their chance of developing infections again is actually relatively high. And I think there is a shift, and if you talk with infectious disease people, and you guys have been more up to date than we are about that, there is a shift again towards much shorter courses, much more on demand. And so I think post-coital or certain situations where people get infections and having antibiotics is actually very good. I listened to a great podcast recently, and we'll have our slides available for you on my website, which is really good. And if you're driving the car, they just run through some cases, about 5 different cases of, kind of test patients and how you manage them. So my 4 points around the management. Longer antibiotic courses are not necessarily stronger. Patients love, my GP gave me the strong antibiotic that time, not the, And the only thing I would say is that men are different from females in terms of the duration. I think that prophylaxis, I break down into non-antibiotic and antibiotic. Commencing prophylaxis in general practice is very safe. I think that we're worried, have I missed something of, do they need to see a urologist? No, I would feel very confident to do that in general practice, making sure I haven't had any obvious red flags, and then really referrals if there's red flags or problems after that. So I feel very confident about prophylaxis. It doesn't mean that they need to be seen by someone, it just means they need prophylaxis. My third topic is the persistent source of anxiety test. I wrote an article last year in New Zealand Doctor, so if you have access to that, it goes a lot more into detail about that. And I'm not here today to talk about whether or not you should test your patients for PSA, because I think it's important for us to know about that, but that's a whole debate in itself. My aim really is just to understand, the pros and cons of the test, know what the current guidelines are, and then giving you a clear pathway for you in terms of your patient. We know that prostate cancer is common. We know that screening is controversial. Nowhere in the world do they recommend population-based screening. Interesting enough, one of our colleagues at Auckland, Cameron Zaga, I think he showed that there's been 4 million PSA tests in the last 6 years in New Zealand. So in terms of a health cost, it's amazing. And also I had one of my colleagues from Australia over, and they said actually the government only funds a man as a part of a screening to have a PSA every year. So after that, they actually have to pay for it themselves. It'll be interesting if we introduce that in New Zealand, because I think that a lot of men do get a lot of PSA tests. There is benefit from reducing the risk of prostate cancer death from screening, but we can't. We also need to discuss the risk of overdiagnosis and overtreatment. So every time I see a patient, I'll say, it seems best that we find something early and we treat it early. But the problem is that we've also got to be aware that sometimes that's not the right thing, because if this is your time before you die from prostate cancer and this is your life, I could treat you now and you'll die, and I'll go, oh great, I stop you from dying of prostate cancer, but you may never have died from prostate cancer. And so, patients need to be aware of that. And I think, there are some decision aids. This is the Kupu website. Some men may find that beneficial. At least it's somewhere where you can direct people, because often in that consult, But the thing that scares me is this, and I don't know if you're like me and you get the case book and you always read through it and you go, I'm sure that could be me. And I think, and particularly from what my wife says, as a general practitioner, you can feel, because as a specialist, I can often go, well, let's just get a CT, But you're always going, hey, well, I don't necessarily have that. And so in terms of treating patients, being aware of that. And if you look at HTC cases, there have actually been a number around PSA testing. And you'd think that it shouldn't be, because screening doesn't benefit anyone, so surely you can't get done for that. But, these are 3 cases in the last 3 years of HTC cases. And I've read in detail all of these cases just to get an idea about it. And I think that the key point that was made in all of them is that if you divert from a usual pathway as the general practitioner, the onus then becomes on you in terms of the follow-up pathway. So you just need to be aware of that in terms of following to the guidelines. And the key thing being is that actually the clinical management for these patients, I had an 87-year-old who came to me, he had metastatic prostate cancer. He said, my GP didn't test me for it. And, we had a discussion. I said, hey, actually, you've lived 87 years, and we may have diagnosed this when you were 75 and you had radiation, surgery, all these kind of things, and we may have actually ruined your quality of life, whereas actually you've made it 87, and now finally we've only just found it. So, it is a discussion that we have to have with our patients. But it's complex. We find it complex enough. How are we going to kind of impart that on our patients? And as soon as we use the C word, everyone gets very concerned. So these are the guidelines. And again, there's a document, and I'm not going to go into this because you can access this, but there are some kind of straightforward pathways for it. Should we do a rectal exam? Interestingly enough, I was just at our national conference just yesterday, and one of the young Māori trainees presented a project from the Bay of Plenty, where they found actually that there was a real reluctance of Māori people to be tested for prostate cancer because of the rectal examination, and whether or not we should be considering that in terms of being culturally sensitive or not. So I think if you feel comfortable and confident, it's a great test. So don't ever stop doing it, but don't ever also let it be a deterrent for people to be tested. Family history is important, but the hard thing is really what is an abnormal PSA? Because there's no level of PSA that says you do or you don't have cancer, and the PSA can go up for other reasons, and we often have to have this discussion with patients. The key thing from my point to take away is one PSA test is never abnormal. You have to have more than one PSA. But reassuring the man that, hey, it's fine for us to wait 6 to 8 weeks before you do another, that's often a difficult conversation. And explaining that there is variability in the PSA. You can do your PSA every day of the week and it would be different every day. I've had patients who've done their PSA in the morning and in the afternoon and it's been different, so it can be different. Conversation I often have with men is, well, should I have my PSA every 4 weeks or every 6 weeks? And having to have these discussions with them around, the timing for this. And often it can, again, sticking to guidelines can be very helpful in terms of that. So again, it's hard because some people are more at risk. So if you have a family history, we would recommend every year. But the guidelines for those men with a normal PSA would be every 2 to 4 years. So these are the current cut-offs. And, in terms of the e-referrals, these, if you get sent a PSA, then we will be looking at this in relation to this. Are we being ageist? One of my colleagues is very strong about this, and I'm think physiological age is very important, much more important than chronological age. And if you do have a very fit patient, and you send in a referral and you say, hey, this patient is extremely fit, then we do take that into consideration in terms of the referral. So if you are ever doing that, include that in your referral. Why are we doing PSA test in the end? In a younger man, we want to capture it early, but we've got to remember that there's a very long lead time. The harder thing is in the older person, we're not necessarily wanting to catch something early. We're wanting to avoid symptoms of metastatic disease. And we've got a much wider playing field. So we're not trying to capture this at the early stage, which often can be difficult for explanation to patients. So my key thing for you is to inform the patient from the outset what the plan is, to make sure they're going to benefit from this. If the test is above the reference range, repeat it. If it's still elevated, then refer. Don't take on the burden of what you should do in that situation. What has changed? Well, MRI has changed, different ways of doing biopsy. So when we see the patient, we're going to talk to them about that. And MRI testing, I think, is a growing field. The hard thing we have in New Zealand at the moment is there's a real disparity between what happens in public and what happens in private. In private, everyone gets an MRI because we think that's a great thing. In public, it's a bit more in between. I think with the Ministry of Health, you may see that change. The concern really is in terms of the resource. In Auckland, Auckland DHB, we've just lost 3 of our MRI technicians. So there's a massive strain on MRI in the public hospital. Under 40s don't do a PSA unless you do a rectal examination, you feel something very abnormal. And I do find young men have smaller prostates. They will feel more firm. That does not necessarily mean that they are abnormal. Thank you. And 80-year-olds, people with urinary symptoms, almost always that's from benign prostatic hypertrophy, not from prostate cancer. So my take-home message is If you're going to test, refer or follow up. Have it in the system. It seems obvious, but it's more difficult often, and there are grey areas. But the key reason is not to shoulder all the risk. And biologically, nothing in prostate cancer ever happens fast. Even if you say you've got a high-risk cancer, that does not mean that you need to be treated tomorrow. Psychologically, has a massive impact on them, and I think it's important to acknowledge that when discussing with the patient. But my job, our job, is to reassure them, hey, there is time to work through this. No rush should ever happen in prostate cancer. Thanks.